Good morning. Welcome to Psychiatry Grand Rounds. My name is Gurman Sidhu, and today I have the pleasure of introducing my colleague, Dr. Jean-Maurice Salcedo, the future chief here at the Psychiatry Department of the next academic year. She has done her Bachelor's of Science from College of William and Mary with a double major in kinesiology and sociology with a concentration in women's study. She has her medical doctorate from American University of Antigua, and she also has a MBA, and then she is currently a psychiatry resident here at ETSU. And she'll be telling us a little bit about Alzheimer's today, so please give her a big round of applause.
Yay. Well, thank you guys. Thank you, Dr. Sidhu, for that introduction. Can you guys hear me okay? All right, so pretty much, as you can see, what I'll be presenting on, because as you guys know, I'm quite passionate about just geriatric medicine in general, and wanted to kind of give you an overview here. So I was really I had this introduction essentially kind of with hopeful more participants in the audience, but we'll work with what we got, okay? And so pretty much, essentially here, so before I begin, of those in the audience, how many here would want to live to the age of 80? Right? Okay, good, so we've got a good raise, and so essentially, most of us would want to live at least to the age of 80. There's lots of things to do in life, right? And so here, as far as what we want to do, obviously, as we're getting older and older and living longer and longer, it's a beautiful thing. But certainly, as we're seeing, this might be more so also one of the risk factors. And so certainly we'll go over that. Now, so let's fast forward a little bit. So all of you guys who want to live to the age of 80, and I want you to kind of pick two people around you, okay? So just pick two people that are just around you, okay? So now let's fast forward. Now we're 85 years old, and there's the three of you guys, okay? So we're all 85, fast forward in the future. And so essentially, of those three, you have Alzheimer's disease, okay? I know that got a little morbid, but for the most part, as we go over more of the factors, 1 in 3 will get Alzheimer's disease. And so, of course, you're probably going to say, I'm not going to get Alzheimer's disease. So then of the three that you've just, the other two that you've looked at, you're a caretaker, okay? And so the reason I wanted to present it in that way is it affects all of us, essentially one way or another. And so what was really intriguing in that introduction, essentially that I'd seen actually in a previous talk that I had seen, is essentially bringing it home, okay? So all of you guys may or may not have had exposure to Alzheimer's disease or dementia in general. However, this is something that's near and dear to my heart, as it's been very, it's affected both sides of my family and now my future family with my future father-in-law. So I want to go ahead and present, certainly here, Alzheimer's disease. And I'm going to provide an overview of risk factors, current treatments, potential future treatments, and certainly what we can do as mental health providers to help improve the quality of life for our patients and their families. So certainly here, just a disclaimer that I have zero interest in anything with that, okay? Well, I have more interest, but you know what I mean. So as far as my advisors, I really want to thank Dr. Bench, who's one of our VA attendings, who's got interest in dementia and has been guiding me. And of course, Dr. Jerry McKee, who is our psychiatric pharmacist over at Woodridge, who's always been guiding me every Friday morning in our Friday morning rotation. So thank you. All right, so for objectives, we want to differentiate today the difference between normal aging and dementia. We want to provide an overview of Alzheimer's disease. I want to elucidate the current facts and figures, highlight some risk factors of Alzheimer's disease, review the current treatments we have real quickly, and then certainly assess the potential for future treatments. I want to help kind of talk about ways that we as mental health providers can provide techniques or ways or resources for our patients and their families to help improve quality of life. And certainly in the very end, it'll be a list of some resources that I'm not really going to go over in detail. It's more so for those, if you want to watch the video, again, I've heard it'll be uploaded, so you'll see those details. All right, so what is normal aging? So the main thing to know about it is it does not interfere with our activities of daily living. Okay, you're not going to have any deficits with the ability to learn, nor have any effect on your independence. We may have some of that slow mental processing, like walking into a room and forgetting what was it that I was going to get. Okay, so that's pretty typical. I think most of us have, encountered that. So essentially, as far as the difference between, one of the main things to emphasize is that normal aging does not include dementia. Okay, so here is a way, I guess, just kind of differentiate and compare and contrast what would be considered normal aging or normal age-related memory changes, as well as the symptoms that indicate dementia. So as mentioned before, the normal age-related, you're still functioning independently, there's no changes essentially in your activities of daily living, and you're able to recall, describe incidents of forgetfulness. You may forget something, but it'll come right back to you, okay, eventually. And with regards to directions, you may have to look up directions, but again, you're not going to get lost. And certainly here, you may have trouble finding words in speaking. However, you're not going to have difficulty with conversations. And so conversely, as you can see there on your right, are some of the symptoms that are complete opposite of that, essentially. And so, performing daily tasks, these are the types of questions that we ask our patients. Are you able to still pay your bills on time? You take care of your medications, all of these things that we typically are very used to doing and that we can't do anymore. You can have difficulty recalling specific instances. You can get lost. And this is where those questions are, driving to familiar places and unable to follow any directions. And certainly with word finding, you might just have difficulty finding words or maybe interchanging words, essentially saying, instead of saying foot, that or shoe, that thing on your foot. Okay, so it's one of those things that, word finding and the cognition is affected, and certainly telling stories over and over, is pretty classic with regards to that. And certainly lastly, poor judgment and decision making is certainly affected with regards to dementia. So cognitive domains, so we see this in our DSM-5. And essentially, it's just a formal way of describing what we just talked about earlier. So complex attention is effective, executive function, learning memory, language, perceptual motor, and social cognition. Again, all of those examples were previously depicted. I'm just going to go over this real quickly, so we're not going to read the full thing here, but certainly in psychiatry, of course, I've got to bring up our DSM-5. So on DSM-5, dementia or neurocognitive disorders are differentiated between mild and major neurocognitive disorders. And so here in the mild component, your cognitive decline of that patient or whomever you're evaluating is modest. So as far as the decline is pretty mild, the impairment is essentially still quite modest, that it doesn't affect the activities of daily living and decision making. Whereas conversely, with major, as you can see, significant cognitive decline and certainly a substantial impairment in your cognitive performance, or essentially in our neuropsychological testing, you'll see kind of the differences there. Okay, so again, mild does not interfere with ADLs. And the thing I do want to point out, of course, with mild and major, of course, is the interference of what would be considered, change in activities of daily living. But the main things we, of course, have to differentiate is ruling out delirium, which certainly we do almost on an everyday basis, especially in the emergency setting. And then certainly these cognitive deficits cannot be better explained by, be it major depressive disorder or schizophrenia. Okay. So many different types of dementia here. So these are just actually what's listed in our DSM-5. However, currently there's over 70 different types of dementias out there that's been documented at least. And so Alzheimer's disease is our most common, and so that's what I'm going to focus on today. But I'm sure at some point or other you guys have been exposed to all the other different types of dementias that you see here. So you've got, with regards to, is there a vascular component or traumatic brain injury or substances? We deal a lot with that, right, with alcohol, certainly, and other substances that we deal with, especially in our VA population. Okay. And just more detail as far as specifiers, we've got Certainly, if there's a behavioral disturbance component, that's certainly what makes it a little bit more difficult. And we see that a lot. And I know for second year, especially with admissions and such, we'll call them kind of like our geriatric dumps, so to say. And it's really a sad concept where we really don't have a place for a lot of our patients who do have behavioral disturbances component, and family members just cannot take care of them. And so essentially that's, I think, the push that we should all pretty much support, in essence, to try to be able to find better options for this. And certainly further differentiations between mild, moderate, and severe, depending on what the deficits may be. Okay. So now just a little bit of a backdrop on Alzheimer's disease. So a lot of these facts you're probably going to be quite familiar with, so I will just kind of go over them as towards the end of the presentation is what I really want to be able to focus on. So Dr. Alois Alzheimer, so certainly the disease now bears his name. He's a German psychiatrist who first described senile dementia. And he had this patient, 55-year-old woman, who pretty much presented with memory loss, disorientation, hallucinations, and an untimely death at age 55. And so at post-mortem autopsy, of course that's how we can really only diagnose Alzheimer's disease, still to this day, you saw the thinning of the cerebral cortex, and certainly senile plaques and neurofibrillary tangles were found. So again, most common cause of dementia in the elderly is Alzheimer's disease, and the condition is progressive, it's insidious, gradually affecting a patient's intellectual function, mood, and possibly their behavior. Okay. So now, Alzheimer's is divided into 7 different stages. So this is referred to as FAST. So Dr. Barry Reisberg actually came up with this. He's a geriatric psychiatrist over at NYU, and he kind of helped break down the stages of Alzheimer's. The first stage, pretty much, this is probably where we all are, okay? In essence, you're not seeing anything. And the reason I say that is the symptoms of any sort of dementia, in essence, more so towards the Alzheimer's, they present 15 to 20 years, later, okay? So stage 1, hopefully that's where we're all at. Stage 2, still very mild cognitive decline at this point. That's still not noticeable to others, but you may be noticing it, okay? Whereas stage 3, now this is when friends and families, coworkers, or the people that see you on a daily basis, they're starting to see, essence, some cognitive decline in what they're used to with regards to interactions. Whereas stage 4, certainly a little bit more of a moderate cognitive decline, and this is essentially the stage that we might get our patients. Where they come in and family has already explained that there's been some cognitive impairment that they've been noticing. And certainly in the latter stages here, so moderate, essentially a little bit more severe than that initial presentation. And then the last 2 stages, stage 6, severe cognitive decline. Essentially this is really kind of the beginning towards the worsening. And stage 7, certainly that's going to be the very severe cognitive decline. And in essence, this is where the stages, when they talk about Alzheimer's being actually number 6 killer, and we'll talk about that in a little bit. Essentially, how do people with Alzheimer's die? Okay, so what's going on with these patients? So as you can see, as the disease progresses, you'll have the individual lose the ability to respond to their environment. Okay, so essentially with control of movement, conversations, and helping with their daily personal care. So for the most part, as they progressively get worse, they're going to have difficulty eating on their own, using the toilet. They may not be able to sit up straight on their own. And really where it becomes more so towards mortality is you're going to see muscle rigidity, so certainly immobility. Okay, so essentially with those in mind, if they're not able to move, decubitus ulcers, infections. They may get blood clots, okay, so PEs and such. And so you can kind of see the progression of what happens. And lastly here, as far as swallowing is impaired, essentially that's one of the more common causes because the patient forgets how to swallow, they may aspirate. And certainly pneumonia is one of the final demises there. And another thing I found that was interesting, reflexes become abnormal. So actually some of our more infantile reflexes actually return. So on physical exam, they may have that grasp reflex or the suckling reflex or even Babinski. So it's literally almost kind of a rewinding back to our infantile stages. It's essentially what you can see. Okay, So as far as what we know of Alzheimer's, certainly there's so much research has been going on for decades, but the theories that we've had is essentially the amyloid theory or hypothesis, and as well as the built of the hyperphosphorylated tau proteins. And so essentially with these proteins, what's going on, the misfolded proteins essentially are sticking together and then certainly causing a disruption in the synapses in our neurons. So this is more so of a picture here with regards to the amyloid beta theory. So as you can see there on the far left, if my pointer will work here. Well, the far left, I don't know if you guys can see the pair of scissors up there. So essentially, think of that as the enzyme. The enzyme is called BASE, your beta amyloid precursor protein enzyme. And what that enzyme does is it cleaves the amyloid precursor protein. And so what happens is if it keeps cutting the edge of these proteins, you're going to have a whole bunch of the APP protein essentially accumulating within your neuronal spaces. And so here on the right is a depiction of the tau proteins essentially, or the neurofibrillary tangles. And so what you can see here is a misfolding certainly of these proteins is what interferes with the synapses of your axons that you can see there, and it's blown up with regards to what the synapses are doing. So essentially with Alzheimer's, dementia, it's getting clogged. It's eventually what's going on, so you can see the synapses are not going through. Okay, and this is just with regards to tau protein that's essentially found in the microtubules of our axons. And as they continue to be cleaved and hyperphosphorylated, they start to form these helical proteins that then ultimately, again, clump together. And this is what we know of as the neurofibrillary tangles. Okay, so this next slide is going to go over some facts and figures that I found really interesting. Alzheimer's.org or ALZ.org provides a lot of really good resources with regards to Alzheimer's disease. So let's just watch a little bit. It'll be about a minute. So just figured that'd be more interesting to watch than me talk about it. But in essence, this next slide was because I was scared that that video might not play. So it just kind of reviews what you just saw as far as statistics. I always get tongue twisted saying that. The statistics involved with regards to what we're seeing currently at present day as far as how many Americans are living with Alzheimer's disease. And so as you can see here, the impact of what we will see in family, but also certainly the financial impact that we'll have with our country, and that's just with our country alone. And so you can see certainly on this as far as how much it might cost. And I wanted to point out on the very bottom, in 2007, the lifetime cost of care for a person living with dementia was $341,840. So 70% of this has come out of the personal pockets or out-of-pocket costs for families. So preparing for it, it's what's going to be really important, and that's what I'll kind of highlight a little bit more later. Okay. So diagnosis, essentially, of course, we're going to obtain our history and physical, certainly find out what the history of the present illness might be, mental status exam, of course, we'll have to determine, and certainly the cognitive screens that we can perform and generally work with to help in diagnosis. Now, as far as labs, as we all know, the complete blood count, the thyroid stimulating hormone, vitamin B12 levels, HIV, as well as the possible presence of RPR and VDRL with regards to maybe a previous exposure to syphilis. All of these are organic causes that we do need to rule out that may also cause some dementias. And as far as imaging and what we have, head CT, MRIs, and PET scans are currently being used. We're also starting to use SPECT molecular imaging, as well as functional MRIs, but that's not more so in the diagnostic realm, it's more so on the research side of things. Okay, so we're all generally familiar with this. This is in every field of medicine, not just psychiatry. So generally most physicians and practitioners will start off with a mini mental status exam if there is concerns with any cognitive impairment. And so here with the MMSE, it's a 30-point scale, and essentially the different ratings that you get might be suggestive of whatever type, be it mild dementia to severe dementia, depending on the score. And so here, it's important to note, if you're going to use the MMSE to track a patient's progress, you'll see that a person with Alzheimer's disease, the points decline about 2 to 4 points each year, depending on what you'll see on your exam. Now, this next assessment scale, the Alzheimer's Disease Assessment Scale, this tends to be used more so in a research capacity. So especially with pharmacological studies, the Alzheimer's researchers and such. And what's different with this particular assessment is it evaluates both the cognitive and non-cognitive decline. And so what you see in the cognitive section here certainly is the cognitive domains that we had discussed earlier. That's what's being evaluated. But the non-cognitive section is looking at, you know, the measuring of mood, attention, delusions, or any sort of potential tremors and pacing and such. So those are also taken into account when evaluating maybe the efficacy of a drug that might be evaluated. So as you can see here, compared to the MMSE, the ADAS cognitive screen is more sensitive, reliable, and less influenced by educational level. So I think we're all familiar with this scale here. And I don't think we have any med students, but they know this really well when they rotate with us in psychiatry. But the Montreal Cognitive Assessment is generally what we tend to use as well. Okay, so with this exam or with this assessment, essentially what it can only help detect is screen for mild cognitive impairment. So certainly it's not diagnostic, but this can give us an idea of, let's say you are suspecting, you know, some sort of dementia, and the MMSE was actually still within normal limits. And so if you do still suspect, MoCA would be something good to perform. And I did want to just bring up the MiniContest because I know some of us are working in the settings like an ER setting or in even outpatient. You know, we have maybe 30 minutes maximum to be able to evaluate a patient. So if you suspect, certainly the MiniContest might be a great place to start if you don't have enough time to evaluate fully. So essentially in this MiniContest, you've got 2 tasks that you have the patient perform. So you provide the 3 words, have them repeat it, and then have them repeat it again after a few minutes. And then drawing the face of a clock. So this can help evaluate different aspects of the cognitive domains, and just in essence having them draw the face of the clock with the numbers appropriately set, and then the time that you designate if they can set it in that place. So here again, just a really brief test that you can do in those settings where you don't have much time to perform an exam. So as far as brain imaging, certainly these are currently what I mentioned before, what we're currently using, be it head CTs or MRIs, that will look at the structural image of the brain, whereas your MRIs or functional MRIs and the PET scans are going to actually help reveal more so a function of the brain. In essence, how is our brain metabolizing sugars or oxygen? And that gives us a better idea of what portion in our brain might be depicting a deficit. So this is just a quick overview kind of on the gross dissections there on the left, the classic features of the shrinking of the cerebral cortex, enlargement of the ventricles, and the shrinking of the hippocampus, which is one of the main structural components in the brain that we do see a lot of the deficits when it comes to Alzheimer's. And certainly here, your scans on the right certainly depicting the same thing. As you can see, the ventricular region is certainly enlarged, and then going down further, the hippocampal space is a lot smaller, is what we would see on a typical head CT. And so here with this MRI, essentially the right image is the normal comparison to the left, which depicts somebody with mild dementia or mild Alzheimer's disease. And essentially, the color codes will show you, and the green is what I really want to point out, because the green is what determines our hippocampal space. So it's a lot smaller, as you can see on the left, on top of course, the cortex, the thinning there of the cortex. So essentially, again, these are some other scans that we can use if there is a question of Alzheimer's disease. But sometimes initially the MRI will be normal. So that's really something important to note. Even if there's suspicion and it comes back normal, certainly maybe a year or two later it might be completely different. Okay. So this is one of the things I really want to focus on are the risk factors, because essentially right now as far as treatment, which we'll talk about later, we're really at a standstill as far as what we could do for Alzheimer's disease. So what can we do in a more preventative aspect? So with age, well, I don't really want to prevent age, and we'll talk a little bit about that later. Lifestyle, cardiovascular health, family history, and certainly genetics, the social and intellectual activity of a patient, insomnia and depression as particular risk factors. And of course, I highlight insomnia and depression since that's something we deal with on a daily basis with mental health. So with age, and kind of what I mentioned earlier in my intro, essentially the greatest known risk factor for Alzheimer's is age. So as we're living longer and longer, certainly we're going to see more and more Alzheimer's. So just living beyond the age of 65 is essentially the most statistically powerful risk factor. And as you can see beyond age, so it's 10% prevalence as you're age 65 and above, which can essentially double every 5 years. And above the age of 85, the risk of getting Alzheimer's is now 40%. So just age alone is one of the, again, statistically powerful risk factors that we are aware of to date. Now, lifestyle and cardiovascular health. So certainly this is where we might be able to help influence. And so with regards to medicine, this is what we're always aiming and shooting for, right? So modifying our lifestyles, be it exercise, smoking, as you can see there, high blood pressure, cholesterol, all of these things, poorly controlled diabetes. And so essentially these factors can be modified, and so certainly helping guide our patients or their families in helping make these changes, be it a regular exercise or eating fruits and vegetables, more of that like Mediterranean diet, essentially can help decrease that risk of developing Alzheimer's. And for an up-to-date search there's the Neurology Journal in 2012 concluded that the fastest cognitive decline was observed in those with both obesity and metabolic syndrome. So within mental health, certainly metabolic syndrome to me stands out. We've got medications that we prescribe every day that can contribute to this. So we're just as much responsible for what might be a risk factor for all of our Alzheimer's patients. Okay, so family history. So essentially most cases of Alzheimer's is sporadic. However, if you do have family history, as you can see here, for a patient who actually develops Alzheimer's, their offspring has a 20% chance of developing Alzheimer's. And of their second degree relatives, a 10% chance. So there is that prevalence found there. Now, certainly possessing the APOE gene, which we'll talk a little bit about later, more so in genetics as a component, as well as trisomy 21. So for trisomy 21, I think most of us are familiar that they'll have pretty much the extra copies of chromosome 21, and then that's what actually carries the amyloid precursor protein. And so certainly a higher level of that amyloid precursor protein, as we'd seen in previous diagrams there, will increase their potential for that being cleaved and getting in the way of our neuronal synapses. Okay, so with regards to genetics, now the component of genetics where that predisposes a patient to a younger onset is what we just refer to as deterministic genes. And so in essence, these individuals that actually get that genetic component from mom or dad or both, certainly will increase their chances of developing Alzheimer's at a much younger age, as young as possibly even 30 years of age. So, thinking about, I know generally when we're trying to diagnose, with a younger onset of dementia, frontotemporal always comes to mind, right? So as far as a younger presentation. But so still keep this in mind, that this is a possibility in the younger presentation, that there may be a genetic factor involved with it. So, of course, APO, the E4 form of the gene, that's one of the potential risk factors. So really here, everyone, all of us have APO, lipoproteins that we inherit, but the three forms that we have is the E2, E3, and E4. So essentially, kind of from this slide, the main thing to take home from that is E2 actually decreases your risks of Alzheimer's. E4 increases your risks. Whereas the E3 version, that's the most common that you'll see in the US essentially. And there's really, that's neutral, so to say. It doesn't increase nor decrease your risk. So the way I just remember it is E2 is that lower number, so there's a lower chance of you getting it, versus E4, which is the higher number, increases your chances of Alzheimer's. And as you can see here, pretty much just having one or two copies of this, it doesn't necessarily say you'll get Alzheimer's, but certainly, again, an increase in your risk of potentially getting Alzheimer's. So I want that E2 gene. Okay. Now, as far as, and that's kind of what I explained there, but on the bottom portion, that researchers are estimating that between 40 to 65% of people that are diagnosed with Alzheimer's have one or two copies. And again, just more so, it is a risk gene as opposed to a diagnostic gene. Okay. Now, social and intellectual stimulation. So what do we mean by this? So again, we're talking about risk factors, right? So in essence, a lot of the articles and papers that I was reviewing showed that lower educational levels, less than a high school degree, appears to be a risk factor for Alzheimer's disease. As far as cognitive, social, and intellectual activity, joint along with higher education, certainly the work that you're doing happens to be seen as a way to decrease that risk of cognitive decline, in essence by increasing what's been referred to, and you'll see that or I saw it commonly in a lot of the descriptions, as cognitive reserve. So as far as cognitive reserve, what is it, right? So it's that capacity that our brains can have essentially to reduce or resist that possible damage that we can get. So essentially, looking at it as a way to have more functional synapses. And what I mean by that is the way that we can use the social and intellectual stimulation component is learning new things. Okay, so at first it was thought, hey, let's do crossword puzzles. So technically, I mean, that's how the initial stages of what we can do to train our brain. Well, really, with crossword puzzles, that's kind of been sort of debunked, in essence, because essentially this is already something that you can retrieve. Okay, so the information is there. It's not really anything new that can help expand the number of synapses that you have in your brain. So in order for us to have that neuroplasticity, okay, we hear about it all the time, how can we make our brain that much more flexible to attain more information, is learning new things. Learning a new language, okay, learning how to play tennis, learning how to crochet or knit, in essence, or cook. If you guys don't cook, learn. So pretty much all of this is looking into the different aspects, and so it doesn't keep it as this kind of unilateral way of learning. You're using your senses, essentially forcing yourselves to, hear, see, smell, taste, different types of learning. And so the more synapses you create will increase your chances of them not being clogged up by the neurofibrillary tangles or the deposition of beta amyloid. And I particularly love the bottom line there as far as lifelong bilingualism can actually help delay the onset of dementia by 4.5 years. So thank you, Mom and Dad, for forcing us to keep learning and speaking Tagalog on top of English. So certainly if you learn more synapses that you're forming. Okay, so insomnia has another risk factor here. Certainly, you'll see pretty much any patient that comes into our offices, insomnia is a big problem. And so in a 2016 meta-analysis, a review of those studies that show that insomnia is actually a significant risk factor for all-cause dementia. And so essentially here, what you'll see, one of the other studies that I wanted to highlight, because there were several studies that I had found, in essence what they're saying is that it's been found that sleep might actually play a role in clearance of beta amyloid in our brain. So essentially, most of the studies, some were evaluating maybe REM. I didn't see as many studies that were evaluating rapid eye movement as far as the risk factor for dementia. But what I did see several studies talk about is slow wave deep sleep. So getting that deep sleep, okay, that's essentially, so think of it as the time where your brain and the glial cells, right, our glial cells, think of them like the janitor cells in our CSF, that kind of clear all that metabolic waste that we kind of create through the day. So if we deprive ourselves of sleep, yay residency, pretty much this is what's going to be building up. So in essence, as you can see here, even one night of losing sleep can increase beta amyloid deposition by 5%. So right now they're still looking at changes, or excuse me, more research to see about the long-term effects of this, but just by this alone, you can only imagine multiple sleepless nights, yay night float, pretty much is what's going to be increasing these chances for a lot of people, okay? And so as far as where they're being found, the accumulations are being found in those structural regions that we were talking about earlier, be it the hippocampus or the thalamus. So these two areas essentially are the most vulnerable, especially in the early stages of Alzheimer's disease. Okay. So just more information that I found in some of the research. So compared with individuals without sleep disturbances, the subjects who reported sleep disturbances had a higher risk of incident in dementia. And then I wanted to bring up the sleep disordered breathing. So really the sleep studies that we're performing are really essential because also the sleep disordered breathing increases the risks of Alzheimer's disease. And so in essence, a lot of these studies are starting to show that, and I wanted to point out on the bottom there that it's also what I did see a few articles reflect, and this one I wanted to highlight from the Journal of the American Geriatric Society, is the incidence rates of dementia is not just greater in those who have insomnia, but it's also found to be at higher risk of those who sleep too much. So even the hypersomnolence is also a potential for risk factors. I didn't see too much as far as the explanation on that, but I did start to see that in a few articles when I was looking things up with that. Okay, now depression. So this is kind of part of our meat and potatoes as psychiatrists and clinical providers here, and so essentially depression. So major depressive disorder has been found to be prodromal and a component of Alzheimer's disease. So major depressive disorder, as you can see here, can accelerate brain aging, including some altered DNA methylations and an increase in cortisol. Okay, and we'll talk a little bit more about cortisol in just a second. But so far, what we do know, okay, that the genes, the APOE4 that I was talking about earlier, that predicts Alzheimer's is not a risk factor for major depressive disorder, and then certainly conversely, the genes that are associated with major depressive disorder are not risk factors for Alzheimer's disease. So in essence, kind of that genetic predisposition is looking unlikely. Now, as far as cortisol, okay, so glucocorticoids, pretty much you'll see some of these cases, there's a disturbance in levels when you see major depressive disorder cases and Alzheimer's disease cases. So you'll see a marked degenerative component again in the hippocampus and the site of the beta amyloid deposition as well. Okay, and so in essence, to just kind of summarize what this says is all these these inflammatory markers like cytokines, IL-1, IL-6, certainly these are all potentials to cause a lot of changes that we'll see in both major depressive disorder and Alzheimer's disease. And with that elevation of cortisol, so again, this is looking towards the inflammation and what inflammation can also do in our brain. So what you'll see is certainly a lot of changes here in the cognitive or domains that we were discussing earlier. And that you can see with regards to dementia, there's higher levels of cortisol that's actually found in the CSF. And certainly that's one of the potential risk factors that we'll see with cortisol. And that's pretty much essentially kind of what I just mentioned there to summarize that. Just higher cortisol levels certainly is neurotoxic is really kind of the bottom line here. All right, so current treatments available. I'm just kind of breeze kind of through this because we're familiar with these. This is all the options that we have. So in essence, the acetylcholinesterase inhibitors and our NMDA receptor inhibitors. Those are the only FDA-approved medications currently right now with regards to helping Alzheimer's. And I just kind of wanted to point out the prices. In essence, this is why we see a lot of donepezil being prescribed, because it's certainly a lot more affordable, and it can be helpful, in essence, for all different stages of dementia. Okay, so I'm not going to go over the details here as far as dosing, but what I wanted to bring up in the bottom line and what I wanted to find for myself is how long do we treat our patients for? So pretty much, as far as when you're starting the dosing and you may get up to the 10 milligrams of donepezil, pretty much reevaluate again in 6 months. And this is essentially a decision that you and your patients and the families can make at that point if there's been any effect, so to say, in that time frame. Now, certainly people have been on it for years, and in essence, when it comes to pretty much tons of medications, then you really have to kind of weigh out the pros and cons of remaining on some of these medications, because it may help some, but it certainly doesn't help everybody. And essentially, galantamine as well as rivastigmine, same thing as far as how it helps with regards to cholinesterase inhibition. And memantine. So we've got more moderate and severe cases. This is when we go to memantine, and certainly this has been found to be helpful. And what I did also find is actually the potential side effects are a little bit easier for our patients with regards to memantine. And the combination therapy of both the memantine and donepezil, though that's great, you decrease it to 1 pill, it is very expensive as well, and something to consider. So here, in essence, just kind of the main side effects that you'll see with these medications. As you can see, nausea, vomiting, loss of appetite is pretty predominant with your acetylcholinesterase inhibitors, whereas memantine, maybe at best dizziness, was one of the more common side effects that was seen, and generally a little bit better tolerated compared to the other medications. So moving on, so non-pharmacological essentially options that we have. So there were tons of different options, and I just kind of wanted to highlight some. And as far as exercise, we've kind of already determined and talked about that. Certainly animal therapy is also found beneficial. And we see that in our inpatient settings, certainly when the veterans are bringing in the dogs, or at Woodridge with Molly, I believe her name. I mean, just the look or the feel in that room really makes a difference. So there's definitely benefit with animal therapy with regards to treatment. And certainly other activities, making them, our patients essentially doing things and staying active. But what I will try to highlight a little bit more are the sensory stimulation therapies, including music therapy, mindfulness, and aromatherapy. So real quick on here, this is a 3-minute video. I might have to cut it short for the sake of time, but just wanted to kind of show you, in essence, what might be different here.
Is that comfortable? Is that comfortable?
That's you right there. That's you right there.
Yeah. Is my name on it? Is my name on it? What's the name on it? What's the name on it? Yeah.
Is it you? Is it you?
You don't know it? You don't know my name? You don't know my name?
What does it look like to you?
Maybe it's an A. Maybe it's an H.
I don't know. I don't know.
Okay.
But it's a girl. But it's a girl. I know it's you. And I know it's you.
Well, here we're gonna listen to some music. Brought you a music player. Here, but you have to put these in your ear.
Fast forward a little bit.
Yes.
Here's all with another. Here's all with another.
Yeah, makes you want to dance.
Two. One, two.
I was young.
We were the best.
Remind you the best.
danced all.
You're showing me this bracelet. Let's see if we can read some of this stuff on the bracelet.
Oh, this one.
Yeah, who were these people again?
you.
I know, who's this one?
That's you, yeah.
And what's my name?
Yours is Holly. Right?
Yep,
Right?
that's it.
Okay, so just kind of wanted to show, I mean, certainly that's just one example, but what music therapy can certainly do for our patients, especially if they're quite agitated in the units. So something to really think about, having maybe some, period themes with regards to the decades that we can offer our patients.
Amen.
Okay, so here in a 2017 article, Music Therapy is a Potential Intervention, essentially summarizes different clinical trials that do evaluate music therapy as a part of treatment. It can help reduce mood symptoms, behavioral disturbances, as well as depression and anxiety, as you can kind of see in that example I gave you. And now, certainly this can help protect cognition. So music certainly, again, those neuronal synapses are targeting different components in the brain. And certainly, as you can see here, she was able to kind of come back, right? And, remember her daughter's name. So psychomotor speed, executive function, global cognition, all of these components can be helped with music therapy. Now, mindfulness-based interventions. So here briefly, as far as what we know about it, certainly meditation. So in essence, it's been here for hundreds and hundreds of years. And certainly with regards to mindfulness, it allows a person to essentially control their mind, in essence, where you can pay a little closer attention in a particular way on purpose in that present moment and non-judgmentally. And so, wish Dr. Stoss was here. I know this is his big thing here, but for the most part, what's been found with mindfulness-based interventions is it can show positive effects on cognitive, emotional, and psychological domains. And here with Essence, again, processing speed, general cognition, executive function, they have all been affected in some way if you are able to maybe find time to meditate, okay? Oops. And so here in this study, by Russell Williams et al. Pretty much he reviewed multiple papers, or their group reviewed multiple papers and found significant findings and trends towards that significant reduction in cognitive decline, as well as the perceived stress of our patients. And now aromatherapy, I love this. So the people who know me really try to use a lot of aromatherapy in just everyday life. And what you'll find is, of course, there's a lot of evidence that's been found with regards to what particular aromas can help stimulate or aid our patients with dementia. And so in essence here, with lavender, of course, the calming effect, and it can help with insomnia. So that's pretty commonly known, especially if you go to Bed Bath & Beyond, not Bed Bath & Beyond, Bath & Body Works, and all of those places that you get these lotions and such. And so as you can see here, in a placebo-controlled study in the International Journal of Geriatric Psychiatry, lavender oil that's administered in an aroma steam, so this would be great if we can get this, has shown a modest efficacy in the treatment of behavior in patients. So there is, I think, place for it, but certainly I know we got to watch out for some allergies and such. But just something to keep in the back of your mind that, hey, it's not a drug that will interfere in their body, but certainly something to help calm in this space. Now, in addition to lavender is melissa oil. I've never actually heard of melissa oil, but it's a lemon extract. And so, in essence, with this lemon extract, this is actually the most studied when it comes to Alzheimer's disease, with regards to helping not just calm and relax, but anxiety, insomnia, indigestion, and certainly some are claiming that it can help improve memory. So that combination of lavender, lemon, there's a reason for that, at least in the cognitive sense. And as you can see, some other oils mentioned above, rose, geranium, sandalwood, also have a nice relaxing effect on the body. So, just the smells maybe might help that insomnia, okay? So some things to kind of keep in mind. And some other things that I did find as far as appetite stimulation, as certainly a lot of our patients are not able to eat so much. This actually has been found to help stimulate appetite with grapefruit and clove. Combination of different senses here. So pretty much the bottom line is, there are other non-pharmacological ways that we might be able to try and just kind of see, and more so kind of the comfort and relaxation of our patients. All right, so we talked about our current treatments and what's out there currently or what's been evaluated. So the first one I wanted to highlight, the BACE1 inhibitors. So BACE, remember, is the beta amyloid, the precursor protein cleaving enzyme. So if we can inhibit, again, I would just remember the scissors, right? If we can inhibit those scissors from cutting all the APP ends, then ideally, so theoretically, it sounds like this would be a wonderful way for us to, in essence, decrease that beta amyloid deposition, okay? So actually, with this clinical study, unfortunately, this was halted, I believe, back in June of 2018. Again, it was not found to have been effective, and I was kind of involved towards the tail end of this study because we did have that here at the Innovations Lab at ETSU. And so unfortunately, currently right now, at least BACE1 inhibitors are not found to be helpful. But there's now what's coming up is the Tau RX is a company that's performing what's called the Lucidity trial. And here now they're investigating Tau. And I think this is great because we've been doing a lot of beta amyloid, right? So we're falling out of favor when it comes to beta amyloid, but here it's going to help or look at ways to inhibit that Tau aggregation. So here with regards to the potential delay of Alzheimer's is another mechanism of action that, is being evaluated here. And again, what's really cool with this is that we're also going to be starting that study here at ETSU through the Innovation Lab, and hopefully, I believe from what I heard, sometime summertime, and I be very honored to be a part of that study. So, as far as quality of life, essentially, how can we help improve quality of life? We're not there in their homes, but what we need to do is guide the families. So I brought this book. I love this book. I've been referring it to everybody. Yay, I haven't read it from here, but I use the audio book because most of you guys know I don't read. So pretty much as far as this book. So Dr. Bench introduced me to this book as soon as I got out in the outpatient clinic. And essentially what this book has done is, it's a way to send it back to your patients' families and help them understand kind of the guide from the beginning of diagnosis through all the things that they can really help with. So this even goes as far as legal, help with regards to how we can help these families. And certainly there's so many other things I wish I could talk to, but I know I'm running out of time here. But end-of-life care even. So there's a lot of different details in this book that I think is great for the community. And it's been something I've been recommending also with the patients I've seen in the outpatient clinic, and certainly with family members as well. So actually I just recently sent this to my future mother-in-law as my future father-in-law, Pops, who's got 2 PhDs, a master's degree, and at 85, as an 85-year-old veteran, he's essentially been going through the process of dementia. And so I mailed her a copy, and she calls me back and says, wow, I finally have my own copy. This is what they're using also in support therapy. So, in essence, for group therapy. And so, really good book in case you want to refer somebody, and, fun little stories in there as well. So here, real quickly, I just kind of want to talk about the different programs and certainly the things that are out there for our dementia patients, and specifically with Alzheimer's. And with regards to elder care, I just kind of wanted to hone it in, bring it home to Johnson City. So currently, right now, the average daily cost for an adult daycare in Tennessee overall is $55. So the cost, as you can see, varies from $15 to $115 daily. So on a monthly basis, essentially you're looking at $1,600 essentially, and ranging, as you can see, up to upwards of $3,500 almost. And we see that and we struggle with that in our inpatient setting as far as placement, okay? So certainly who has that kind of money just alone for that patient? Most of these sandwich generations that we call, we've got children we're raising, and then we've got our elderly parents that we're also helping. So that's certainly the financial strain. This is kind of talking about what we mentioned earlier. And as you can see, the average yearly cost, $14,300, which at least is still under the national average. However, with adult daycare costs, it's about $90 a day here in Johnson City, and about $23,400. And to kind of, put that in perspective, the average income of a Johnson City, Tennessee resident is $28,555. So how can we afford this? And so it's really one of those things, and I like in the book, it highlights different things that you can do and work with, lawyers or elder care lawyers and such to be able to help assist you in this process if this is something that you're having to deal with. Now, in the nation, we've got the program called PACE, the Program for All-Inclusive Care for the elderly. Now, not all states do have this program, but it would be an optional benefit that you can look. I do believe TennCare, we do have this program here in my search, and certainly what this can do is it's a team, essentially, the interdisciplinary team, as you can see there, that there are some centers in states. So again, another potential resource for our patients and their families. Now, Medicaid does offer what's called the cash and counseling program. So you'll see that a lot of family members will quit their jobs and stay home to care for the elderly. Well, they're not getting paid for that. But Medicaid, there is an option out there that can be applied for that might help that caretaker or caregiver at home. I know in the VA we have that program, but what about the rest of the community? So certainly, you know, this would be something worth exploring if Medicaid might help cover and pay that family member to stay at home and take care of their loved one. So, you know, with regards to caregiver stress, essentially what this next few slides encounters is certainly the caregivers is what we also need to look out for. They're the ones that are there. They can get burned out. And so essentially all of the signs and symptoms that you can see there, this is essentially, I thought of it as a Siggy caps. And so they do, of course, display their own signs of depression, and it's really important for us to help recognize that because they're the ones taking care of your patients. We need to also help them recognize that they need help or need some sort of respite. So certainly different things that they can go through, like I mentioned, respite services, local caregiver support, and online communities are real helpful. And then of course the alz.org website is wonderful. It's got tons of things that you can look at as far as resources. And as far as what our country is doing right now, so the National Alzheimer's Project Act, so this has been in place since the 90s, but essentially right now the goal is to effectively treat Alzheimer's disease by 2025. That's just in 6 years, so I really hope that they can really achieve this goal, but at least their country's looking at it, but as far as resources and places to go, we still don't have those readily available. And I'll just go through these quickly so we have some time for questions, but some local resources that you guys can look at. If you look up this lecture online, just listed a whole bunch of national and local resources that are available to answer any questions in case you have any. And I wanted to show my nanay, who's my aunt, my mom's oldest sister. She just celebrated her 90th birthday last weekend. Couldn't be there, sorry, I get emotional. She's kind of the grandmother I didn't have, and at the age of 10 is when she first experienced some of the signs, but she's happy. And my cousin, her grandson on the far right, he created this book, because she's forgetting her names now, and sorry. So anyway, so it's really important for us to fight for this, and just my lovely family, and recognize it early, because we're the ones that try to go towards denial and not realize that it's there. But the bottom line for treatment, guys, is essentially do it early. I mean, because you have to wonder, why are our clinical trials failing? Theoretically, it sounds good, right? But the thing is, we might be treating too late, so that's something to consider. I'm so sorry. Anyways, any questions? Dr. Salcedo. I'm sorry.
Hey, Dr. Salcedo, I thought that was a fantastic presentation, and I guess as I'm like watching the very moving video about the music therapy, I can't stop thinking about all the patients we have on the Spruce unit, and I'm like thinking to myself, in terms of, you know, like the therapeutic interventions we have to folks on Spruce, I know sometimes the nurses they'll sort of tailor some interventions for patients that they kind of get to know. But, you know, it seems like, you know, we get these reports in the morning about, you know, patients, they're just sundowning, or, you know, hey, they're getting agitated or aggressive. But I just don't know if you wanted to speak a little bit to, I mean, off the top of your head, is there any like low-hanging fruit or interventions like music therapy that we could kind of easily, and we may not be back at Spruce for a while, but
yes, that's a great
but is there
point.
anything, I mean, that like the music therapy thing, it seemed like so quick and so effective, and like, and I know it's, you know, it's just a video, But anything like that you can think that we could maybe bring to Spruce that would be
Sure.
super easy, super quick to integrate if the hospital would be willing to consider some of that stuff.
Exactly, and I've actually even done this before with a patient, so thank you, Dr. Zaza. It really just makes a change. So generally what I've done is I'll ask for the patients that I did get to work with, kind of, when they grew up. So I've found that pretty much the decade when they were probably in their early adulthood has been really effective. Again, this is more purely anecdotal, but literally just if you can Google it, or actually on Pandora, sometimes you can do by the decades, you can certainly use that as a possibility, because you're right, I don't know where we might be as far as getting the funding for the hospital, but that might be something to consider. It's real easy. Everyone has a phone. If you have somebody who's agitated, I'm not saying it's 100% foolproof, because we're quick to grab that Ativan, which we know is not great for our elderly patients. However, certainly for cases of safety, it might be helpful. But that might be something to consider, and maybe even with kids in the child and adolescent. Certainly music just connects us. So,
I thought that was a great presentation too. Thank you very
Definitely.
much for doing it. Do you have any sense of the comfort level that primary care docs and ER docs have with diagnosing dementia? Because I've heard stories about just saying, no, you need to go see a specialist, and there are so few specialists available.
You're absolutely right. I guess when you asked that question, I just kind of thought back of us in our ER setting. I don't know. I feel like the answer might be no currently. I mean, I don't want to blanket statement that, but I feel like there's a lot of still uncertainty, and they do want to send to the specialist. But I think starting off with a MiniContest, if we can empower our colleagues in family medicine, internal medicine, and other fields of primary care, start there. And at least that's something that maybe they could do to help identify, is there's a problem and they're still not comfortable, certainly then, because you're right, there's very few psychiatrists in the area, and certainly neurologists are also involved here, but that might be at least a place to start.
All right, thank you so much.
Thank you, guys.